Are we ready, Mike?
Yep, perfect.
Okay, so good afternoon, everyone. Welcome to the next in the Networking Health Primary Care webinar series. It's been a little while since we've listened to Mike and his infinite wisdom on the NHS. It's been a busy sort of few months for everyone, but now the spring is here, things are opening up and we're all off to the pub after this. Want to go on to the next slide, Mike? That'd be great. So Mike's going to be talking today. Oh, Mike, sorry. Yeah, that's fine. We're doing networking health next. Oh, it's gone back. Right. So you want to click to the other one, Mike, first? Great. Okay, so just a little bit for those of you that aren't familiar with networking health, which actually, unfortunately, is actually most of you on the call today know who we are. But for anyone that doesn't, we are a management consultancy and training service provider working within the pharmaceutical, medical device and NHS healthcare arena. And there is a team of myself and Steve, as well as a much wider team of medical and business associates, and we can help you with a whole variety of tasks. That's fab, Mike, if you want to do the next slide. So that's just some general housekeeping, but we can skip on from that now because I think that's covered that. So over to Mike, who we will leave you to introduce yourself to the group, Mike, and to the wider audience that might be watching this at their leisure later in the day or another time. So over to you, Mike.
Thank you very much, Mel. Am I on? Yep, I'm there. Good. So thanks very much for joining me, everyone. It's really good to see your names on the screen. I can't see your faces. So look, just a reminder, I'm Mike Smith. I am a GP partner for 2 days a week. I am still very much involved in NHS general practice. I'm currently doing a placement, a fixed term contract with a digital health provider at the moment. But I'm also the medical director of Networking Health, doing some very, very exciting things at the moment. It's absolutely been meteoric, the sort of escalation of activity. It's wonderful. I'm also a occasional radio doctor on LBC, and I have got a new podcast which is getting about 1,500 downloads. So it's officially the most popular new healthcare podcast on iTunes and Spotify. It's called The Placemat, and we had a wonderful guest last week. We had Kieran Bracken on, who gave an eye-watering story of his own encounters with the medical industry. Just as a heads up, I'm interviewing our next guest immediately after this webinar, who is, I will keep it quiet at this stage because I've realized this is being broadcast. Okay, so look, I'm going to tell you a little bit about the white paper. It's actually quite easy to tell you about the white paper because all it's doing is confirming what we already know. So what it is that if any of you have listened to me speak 6 months ago, and I told you that the way that the NHS was going, this is now the government putting it into force a bit more with a legal framework around it. So it's removing all of the boundaries that the Lansley Act in 2012 put in, and it's not just removing them, it is smashing them down with much aplomb. So it was published in February 2021, and it was leaked, like all government white papers were leaked, to test it on its audience. And when it landed quite well, the government said, yes, that is our white paper. Oh, how did everyone get hold of it? How suspicious. And the reason, whenever there's a document like that, if everyone thinks, it's all right, then you realize that it's not because it's good or bad, it's because it doesn't say much at all. So broadly speaking, it doesn't say that much at all other than things we already know, but there are some things we can read into it. So it was called Integration and Innovation, Working Together to Improve Health and Social Care for All. That probably cost them a six-figure sum at McKinsey to come up with that title. Once again, you get the theme of it. But basically, Simon Stevens, ever since he took over 8 years ago, has been trying to undo the Lansley Act. He was absolutely against CCGs. He's been against the idea of devolved decision-making for general practice general practitioners on a board, on a clinical commissioning group. And actually, if you look at every action he's made within his power, it's been about undermining their authority and undermining and sucking more power out to the top. So, you know, NHS England, don't forget, was supposed to be a hands-off, very small body called the NHS Commissioning Board. And as soon as Simon Stevens got his hands on it, he rebranded them NHS England, even though their name is still the NHS Commissioning Board in the legislation. It's just their brand name is NHS England. And he's basically made them a much more powerful beast than they once were. What he's been doing, he's traditionally a Labour guy by background. Bear in mind, that's some swing considering his predecessor, David Nicholson, was a communist. So at some point in the next 20 years, we'll probably have a Liberal Democrat, and maybe in about 70 years, we'll have a Tory in charge of the NHS. But he's been lobbying the government, which has been no mean feat, to say, look, do this for us, because these are the proposals we've made. Simon Stevens has got his wish about combining NHS England and NHS Improvement. So that means that whereas there was a commissioner and a regulator as two separate organisations that were obviously at odds with each other, what he's managed to do is bring them both together so that actually the commissioner and the regulator are the same body. Now, once again, that obviously poses some problems, which I'm sure I don't need to spell out for you. What's interesting is the sneaky stuff that Matt Hancock and his team put in this white paper that Simon Stevens at NHS England and his team weren't expecting. So look, I hate this type of stuff, but there were themes in there about working together and supporting integration. I mean, as long as I've been in the NHS, they've been talking about integrating care and joined up care and partnership working. And I think that, you know, I'm not being cynical, but this document basically is saying, okay, everyone, we're going to make it law that you all have to work together. I don't think that getting everyone, you know, forcing everyone into arranged marriages never works out in healthcare. But it basically, the positives of it is that there is a lot of stripping out of the needless bureaucracy. So the double whammy of leaving the European Union and also the rules imposed in the Health and Social Care Act of 2012 mean that actually there's a lot less procurement and that people can just use their judgment now to work with providers and to work with suppliers. What they want to do is that they want to make sure that the public starts believing in the NHS again, because although there is a general love for the NHS and people have been clapping on doorsteps at Thursday, what they've shown is that over the last 10 years, there's been a more dramatic decrease in faith in the NHS than there has in the previous 65 years of the NHS's history. So whether we like it or not, people still do love the NHS. They just don't love it as much as they used to 10 years ago. And I think, you know, we all recognise that, both either as patients or as people who work in this sector. The way patients speak to me as a GP now, I can't believe it. You know, people are so rude to healthcare professionals now because of what they expect from the NHS. And I don't really blame them. I just blame a system that's sort of led them to believe that the NHS is something that it's not. That's a whole different story in itself, and I could speak for 45 minutes on that. There was additional proposals to support public health. Once again, that included the abolition of Public Health England. So, you know, Public Health England, don't forget, was a bit of a sad story, really, because after the pandemic, when they realised that there was a total cock-up, and there was a total cock-up, and once again, what remains to be seen is whether the rest of the world has cocked up as much as us, not whether we've cocked up less. They were looking for a scapegoat, and once again, as I predicted, because once again, Simon Stevens has never been a fan, and neither has Hancock. They blame Public Health England. So Public Health England is officially going, and Matt Hancock briefly toyed with the idea of replacing it with another organisation, and I can't remember what it was called. It was called sort of the Council of Healthcare Scrutiny, but actually that didn't sound tough enough. So he's now called it the Health Protection Agency, which sounds like something from a spy film. And the only doctor who went on television and didn't slag off the government's handling of it, Jenny Harries, has been appointed the chief executive of that. So it goes to show, if you do what the government says, they will reward you with positional power. God, I'm sounding really cynical, but sorry, this is actually what's happening. What's really interesting is that they said there's a mention of social care in the paper, and what it says is we need a strategy on social care, which actually everybody's been saying for the last 20 years. In fact, the last manifesto of Cameron's government when he got re-elected was, we will publish a strategy on social care. We've been waiting ever since. We all know it's a problem. We just don't really want to tackle what the problem is. When we all know what it is, people aren't paid enough, people are getting sicker, people are getting older, and we're relying on people volunteering too much. One thing I do welcome in it, though, is that there was a real emphasis on quality and safety. What isn't clear about is who's going to regulate that. And it's a bit woolly in terms of, it seems to imply that it's going to lie somewhere between NHS England and the Department of Health. But once again, we'll wait to be seen. So once again, this is a long document, and I love when I can summarize a really long document in 5 lines. And I was struggling for the 5th line, to be honest. It just didn't look like enough when I'd written 4. So I think the main theme that comes out of it is that competition is just not going to be a thing in the same way. So what I don't want people to take away from the white paper is all of a sudden it's going to be back to the heady days of NHS and no private providers and no third sector organisations. That's absolute BS. What this means is that there's not going to be as much scrutiny. So there's not going to be 4 rounds of competitive tender going to an independent panel from a group of GPs 100 miles away. Actually, people can use an element of common sense. And yes, there will be processes that support the appointing of providers and suppliers, but they won't be as rigorous or as painstaking as they were before. So I think it's really important to say, although there is removement of the competition and procurement rules, there will be these sort of safeguards in place. Now, you know what the NHS is going to do. We're highly unimaginative. You'd think that they would do something clever and innovative there, but no, what they'll have is some sort of competition panel or some scrutiny panel that sits alongside it, and they'll pay a load of money to a bunch of people who should be at work doing other stuff to say that the process is fair. The other thing that I'm very suspicious of is that it devolves to local systems and leaders. Now, it goes to show you how hospital-centric the NHS is, because it then sort of goes on to sort of define those leaders as being, look, I'm going to summarize, the chief executive of acute trusts, that, you know, they all from large foundation trusts. You know, they're not talking about primary care. You know, they don't want primary care screwing this up. We screwed it up once in 2012. They don't want us to screw it up again. The hospital chief execs have been saying, come on, give us a go to run the NHS, and they finally got their way. So you expect to see some of the names. There's some people who are making a big song and dance about social media about how good their leadership is. I think the problem is that in my experience, local systems and local leaders don't know much about their local systems. They know about their organisation in the local system, but once again, I think that this is about, you know, how power is going to evolve. And I genuinely see, and you know, what we're seeing with STPs, which were the predecessor to ICSs, God, loads of 3-letter acronyms, is that essentially the people who run the big hospitals will be running the systems and be given the budget, and ultimately have responsibility for the whole healthcare in a region. So we now know that the ICSs have formed into about 40 plus, about 41, 42 different regions. Interestingly, they fall roughly around the boundaries of the strategic health authorities. And a cynic like me might say we've spent millions, billions of pounds and lots of time just to reinvent strategic health authorities again. But it's the circle of life of the NHS. What's really interesting, and this was the real sort of fly in the ointment for the NHS England, was that Matt Hancock put an entire page in there about how the Parliament will have more say in the running of NHS. And he said that because the government through taxpayers pay for the NHS, they should therefore have more power over how money is spent. Now, once again, I think this is an interesting debate, actually, because I swing 2 and 4th on this, in that on one hand, I think they're all idiots and I wouldn't want them anywhere near running a health service. But actually, Jeremy Hunt spent an entire career as a health secretary avoiding taking responsibility because he kept on saying, look, it's up to NHS England. It's up to you guys. You run the NHS, not us. That's what this new act has said. So in some ways we can hold them more to account, but in other ways it does mean that essentially they can have more power over it. And I think, to try and be more positive about this, what this means is that if someone's trying to shut a hospital in an area, ministers won't then have to campaign to the NHS England, say, don't shut the hospital. They'll be able to intervene directly because they will have say over, NHS trusts and services. What this also means is that, potentially we might see some more, and I suspect this will happen, more NHS trusts being formed. So, there is some talk of a GP federation in Birmingham applying to be a new NHS trust, which I think is really interesting because all of a sudden, as soon as you're an NHS trust, you can't go bankrupt. You're not liable for your own debts, and you can't go bust because you're underwritten by the Secretary of State for Health. So I think that's a really interesting development on this. I think what was most interesting about the white paper was the stuff that wasn't in it, and it was predictably not in there. So there was nothing on primary care. They didn't once mention primary care and GPs. And some of you going, oh, are you just saying that because you're a GP, Mike? No, I'm saying that because the 2012 paper reforms were all about general practice, taking the leadership of knowing what services need to be commissioned. And it was very much saying, because Lansley obviously was heavily financed by Care UK and lots of other private GP organisations, and the fact is he was married to someone who was in general practice. He basically felt that GPs would have more of an idea of how the NHS should be run if it was run by GPs. And pretty much everyone has been pulling against that since that act was passed. Other things that were omitted, community trusts, which I thought was really interesting. So I would worry if I was a community trust now. I mean, bear in mind, there was, I think about 2 years ago, there was only 17 community trusts left in the UK. I think there's about half that now, and I mean dedicated community trusts. So I think, whereas we all saw modernising community services happen under a PCT era, we're seeing that they're just slowly dissolving, and they're largely being assumed by foundation trusts, and those that haven't will be largely assumed by the ICSs. Other things that were omitted, I've already said that social care was mentioned, but it wasn't gone into any detail. And I think that this is that we all know that the biggest pressure in the NHS is the fact that we have more treatments available to a bigger population who are living longer with their chronic diseases. Have I done something there?
Well, that's it's your own slide there, Mike.
What have I done there?
To the screen.
Okay. Can you see me again?
Yes.
I don't know what's happened there. Have I just? Let me just. Sorry. This is why you don't put me in charge of IT.
We've got that on another video, haven't we, somewhere?
Yeah, I think so.
Shut up.
There we are.
Can you see me again?
Yeah.
There you are.
Okay, good. Okay, so I thought the other thing that was interesting is that the paper first finally set out what an ICS will be, and rather than make it one complicated thing, they decided to make it two complicated things. So basically, what they were suggesting is that the ICS should be effectively two bodies, and one was called the ICS NHS body, and the other one would be the ICS Health and Social Care Partnership. Yes, it's exactly what you think. So the ICS body will effectively assume all of the commissioning responsibilities of both NHS England and the CCG. So what it will be given, to put that in its basic terms, the ICS NHS body will be given a big lump of cash by NHS England to cover the vast majority of NHS care for its population, including primary care, community care, etc. And what it will be, it'll be accountable for that budget and how it's spent, and it will be setting very tight financial controls on there, and they basically will need to work out how they're going to address the health needs of their local footprint. Now, once again, you know, I just can't see any imagination happening here. For me, it's not going to look a lot different, because actually, when you're at that scale, you can't really make things personal. You know, when you've got a geography the size of Surrey and Sussex, which is effectively in one ICS, how are you going to tailor care for that population? I don't think that you can't, in short. I don't know if those of you are aware of STPs, which were largely bodies that had no power but were just working out how they were going to spend the money. They're people who are on those boards are largely going to move over into this ICS NHS body. What was interesting is they're not going to merge the NHS trust status or foundation trust status of the providers already there. So let me give you that in a real example. Let's give an example of North London. It is highly likely that the Royal Free NHS Foundation Trust will assume the running of the ICS NHS body, but they will have to appoint a range of people from that meet the local provider landscape to sit on that body, although it will be coordinated by the Royal Free, and the budget will be held by the Royal Free, because, you know, it's not going to be going a massive piggy bank in the middle of a town. Someone has to handle it. But the Royal Free will remain a separate entity. Now, what's interesting about that is that means that the Royal Free could end up spending a lot of money to commission services off itself. And I'm using them as an example. That could be any big hospital trust. And at the moment, it isn't clear where the safeguards lie in that. So in theory, the Royal Free could say, actually, we want all primary care to be provided by us. We don't want GPs to do it anymore. And why is this important? Well, this means that our PCN thing has gone slightly, it's been hit a bit of a speed bump, in that at some point, if PCNs aren't working in an area, the ICS body could just pull their contracts. And that won't be a national thing. It won't be Nicky Kanani saying, oh, all PCNs are going to do this. It'll be in Surrey and Sussex, if they're working out well, they'll continue. In Hertfordshire and Essex, where they're not working out so well, and I'm not saying they are or they aren't in those areas, I'm just using them as an example, they might say, well, actually, we want the community trust to deliver heart failure reviews or medication reviews now. So it's a really interesting time. The NHS board of the ICS NHS board has to be made up as a minimum, a chair, a chief executive, and a representative from every NHS trust, from general practice, and from the local authority, and they can always second additional members as necessary. The ICF Health and Social Care Partnership is basically the partnership for all organisations that are outside the NHS. So that's sort of your social care. You know, it could be the local police service, it could be the local fire service, it could be, you know, Simon Stevens wrote an article in the Times about how the local bin service is going to be helping people with public health, which I just find hilarious. That means that the bin men in Rottingdean could be looking through Mel and Steve's bin and giving them public health advice about what they shouldn't or should be eating. I mean, that thought absolutely terrifies me, to be honest. Not your bin, my bin. So I'm going to start putting stuff in my neighbour's bin so that they get referred to the drug and alcohol service rather than me. So I think that bit's quite interesting. I think there is some questions it raises, though, which once again I think we have to really, scrutinise. Is, first of all, at what level will decision making lie? Because that ICS board, it's not going to make all the decisions for a local service. And let me give an example. I don't think that an organisation that big is going to get involved in who provides phlebotomy in Rottingdean or who provides wheelchairs in Barnet. I just can't see them making that decision. It's too big. So what will happen inevitably is they will devolve a budget and services to another level. But what's really interesting is there isn't that many more levels that it can go to. So I'll come back to that in a minute, but it does raise an interesting question. And I think that the ICSs, the integrated care systems that try and do that themselves will fail, because we barely had enough time to commission services when we had more commissioners around. So what they're doing is they're stripping out clinical commissioning groups, making them into super big ones. And to give you an idea of that size, the average ICS will cover a geography of about 5 CCGs on average. So you were talking about big beasts. I think the other interesting thing is that Matt Hancock has single-handedly decided that what the NHS needs is more Matt Hancock. So it's incredible. I can't even begin. I can't say too much about him because I actually want to interview him on my podcast. But I think it'll be interesting how that plays out, because politicians mixing with NHS England type civil servants has never ever worked out well in the past. But let's see it. I think the other thing that's really interesting about this is that they haven't really thought about the COVID recovery. And what I mean by that is that, we've got waiting lists like we wouldn't believe now. I mean, really, it is, it reached an all-time low when I sent a referral to neurology last month, about 3 weeks ago. And we got a letter back to say the average wait is 64 weeks for a first outpatient appointment. Now, once again, that is phenomenal. 64 weeks. So we're now in the territory where a lot of people will die on waiting lists, which in a civilized country, and once again, I think if we do that, we would argue whether we are being civilized, is horrific. Now, bear in mind, we were in a bad position before this situation started, and all COVID's done is really heighten this. Now, once again, I see opportunities with this. I really do. I think that actually we then have to think what activity needs to go in a hospital, what doesn't. And I think that, if anyone is learning about that quick and fast in this environment and teaching others, it's definitely Steve and Mel. They're, once again, they're really pushing the boundaries on that. And I think that, I am very concerned about primary care. And the thing I'm worried about the most, and some of you might think it's a bit stupid, but I have this awful knack of predicting the future, and I do. And I dig out stuff that I wrote 10 years ago. I wrote an article in Pulse about, how I saw things going. And I even wrote, all it takes is a big global event, like a big national tragedy or a pandemic, and it will really test the boundaries of primary care. And I think I might have caused the pandemic, because I'm wondering whether I'm actually causing these things or predicting these things. But I don't see primary care being what it is at the moment. I think I see it being a lot more transactional. I think the idea of the family doctor and Dr. Finley's casebook is, I can't see it happening. There's not enough of us, and the people making the decisions don't value it enough, that type of NHS, because because the people making the decisions don't need their family doctor to spend half an hour with them holding their hand while they're dying, because by definition, if they did, they wouldn't be in a position to make those decisions. So I think it's the beginning of the end of how we know it of primary care. I think it will still be there, but I think what we're heading towards, and I think we're not heading at, I think we're heading at quite a rate of knots, is a very much American style of primary care. I think what we've done is we've shown the Americans how to do primary care. They've started doing it, and now they're selling our idea back to us, but it's worse. And the Americans do that with a lot of things. I don't know if you've tried London Pride bitter recently, but that's been bought by Asahi, who have totally buggered up that recipe as well. So we've just got to stop selling our own ideas and making people make them worse. Anyway, that's so, will stuff change? No, not a lot. Not a lot. Nothing's going to change visibly for patients for at least 3. In fact, I don't think patients are going to notice a thing, even when it all does change. To quote a very grumpy patient of mine, when I tried to talk to him about ICSs, because he said he was interested in health policy, and I won't swear, but I'll just say effing. He said, I said, oh, they want to go to more locally place-based care. He said, I don't give an F about that. I just want to see an effing doctor. And I thought that really summarized how patients feel about the NHS at the moment. So yeah, it's not a lot. I think what's going to be interesting is with all these things, be it healthcare, be it business, be it relationships, marriage, be it football teams, be it whatever, but anything that involves partnership, as soon as there's money and power involved, it will test those relationships. And I think that all this high-fiving and all this sort of spirit of collaboration and all these well-meaning documents and tweets, which don't mean anything at the moment because there's no money and there's no responsibility in them. It's easy for me to say that I'm going to make a more diverse panel. I'm going to promote BAME communities to have executive roles. I'm going to promote minority groups. These will be tested when they actually have to do it. So I think it's easy to say stuff when you don't have to do it. And I, you know, if you want to give a real example, there's a guy called Rob Webster who runs a ICS in Yorkshire, and he's earned himself the nickname of Yorkshire Jesus at the moment because the stuff he's saying, you'd think he was going to change water into wine up there. Now, when this legislation passes and he has to start delivering healthcare services to a local population, all these people talking about the spirit of collaboration and, you know, all the stuff he's saying is important. Let's see how important it is to him then. I hope he does it, but once again, I think this is going to be a very interesting time. And I think that those people who have been shouting loudest about ICSs and leading them will be the first people that will be called to the guillotine when the revolution comes, because it will change again. If we've learned anything in healthcare, this will change again. In 8 years, there will be another set of reforms, probably by Keir Starmer's government, who will basically want to go back to some more locally based commissioning, and then they'll be saying the same old nonsense that every other stupid government says. But for the record, I don't lean left or right. I think they're all corrupt. So look, this is roughly what it looks like now. This is the Department of Health, and bear in mind, I've really simplified this. Really, I know it's more complicated than this, but I just want to sort of illustrate that, you know, we're at the point now where the Department of Health gives a load of money and responsibility to NHS England and well, they're now NHSE, NHSI, and CCGs, because they basically combine a lot of their commissioning functions, and between them they buy services locally for, you know, in an area. And I think what's interesting is that it's going to change like this, in that the Department of Health with NHSEI is going to give a budget and responsibilities to these ICS NHS boards, who are then going to buy services either from themselves, which is why I've not put a separate arrow to them, because I think it's just laughable to suggest that, you know, a picture of a hospital with an arrow pointing to a hospital, why would I need to put that? So I think they're going to basically decide what they're going to buy off themselves, and anything that's left will go to the rest of the system. But they won't buy it from the rest of the system, but they'll hand all the non-sexy stuff to the rest of the system to work out how they want to provide it. And this is why I think primary care will change, because essentially we're going to get all the stuff that GPs should do, but they don't want to do. It's like looking after old people, doing home visits, looking after people with chronic diseases. And I think that, once again, that needs to be done. But I think the challenge of primary care networks and primary care is it needs to be done in a different way, because there ain't enough GPs to do it like it is at the moment. And I think what we're also going to see is that a lot more providers being brought into the mix. So, you know, I'm involved in conversations with a digital health company at the moment who are making big inroads into a lot of ICSs in providing extra capacity into the system for GP. And I think, you know, once again, this is, you know, the other thing I can say is, if you ever want to turn a GP on, promise them you'll sort out 3 things for them: sort out their workforce, sort out their workload, and sort out their buildings, because they're the 3 things that GPs you'll turn their heads with. So I think, you know, let's say the white paper hasn't passed yet, but it will do. You know, that's just the thing. ICSs are not legal entities yet, so they have no buying power. And I think even when that white paper passes, which will be sometime in April next year, it'll take them a while to work out who they are, and what they want to buy. I think that I've got a nice chilled bottle of champagne in my fridge for when CCGs disappear. I think CCGs have been an absolute curse, a pox on the NHS landscape for the last 8-9 years. And I can't wait till they go. And I will be the last person ushering them out of the car park when the building shuts. Honestly, and on that, have they done anything? Have they commissioned anything original or new to help the NHS? What they've done is that they've just recycled the same old rubbish. I think that the PCNs are also going to evolve, and bear in mind, evolve doesn't necessarily mean a good thing. I think that some will evolve into being absolute white elephants, some will evolve into being more functioning businesses, and I think what we're going to see is a real sort of when the handcuffs are let off PCNs and the hand holding from NHS England stops, which it will stop because they know it needs to stop, and they start saying to ICSs, right, it's up to you to talk to your local PCNs, it's up to you to buy services off your local PCNs. Then we'll see, you know, we'll separate the strong and the weak. Once again, I can't stress this enough that, you know, there's a real problem with the COVID recovery and actually how things are going to go back to normal on a background of a system that was already creaking and at breaking point. And part of me worries that the system's already broken and we haven't really diagnosed it yet. And I think then we're going to be having a very, very different conversation, because then we're going to be in the scenario of we haven't got enough money to fix the system. Why don't we sell Birmingham and Sandwell, that whole area? Why don't we sell it to United Health in America to sort out? Really, we're in that type of territory. And bear in mind, I'm not anti-privatization. I'm really not. I'm just saying it very realistically like it is. And the reason I say that is beforehand, that wasn't possible to do that. It wasn't possible to sell a system to a private company. It is entirely possible with this legislation to do that. And if the chips are down, and if you say to the public, well, you can either have no national health service, or we can subcontract this ICS to a large American conglomerate to run for you, and you know the patients won't pay anything because it'll be the government paying the American conglomerate, so it won't make any difference to them. Then actually, you know, why wouldn't they do that? So it is interesting times, really is interesting times. And actually, I think the thing about interesting times is there's always an opportunity, isn't there? Really. So, you know, whilst somebody's baking, it's time to raid the fridge. So there is a narrow window. Yep. And there's probably around, I think we've got until about 18 months, starting on the 1st of April, 2021, because the legislation will pass around April next year. They're saying it's going to be October this year, but you know what politicians are like. They like a good old argument. They like to claim expenses. So they'll push it forward until April next year. And then it's going to take about 6-8 months for them to figure out what they want to do, who's in charge, what do they call themselves, what the name badges look like, etc. And then once they've finally decided all that, then someone's going to start sort of taking notice. And I think that's a window of opportunity. I think pick the areas wisely, because the thing what I would say to you is know where the balance of power lies. There is no point talking to a CCG now. Absolutely not. They are demob happy. You know, there's a bottle of gin and a party popper in everyone's bottom drawer in the CCG at the moment. They can't wait to leave, because either they're going to retire, yes, great big payouts, or they're going to be moved into the ICS with a sparkling new office in a sparkling new building and finally get their dream to work for an acute trust, because that's where everyone really always wanted to work. They didn't ever want to work in a CCG building, did they? And I think the other thing is that, you know, your idea and traditional models of how you do in this industry, how you do as industry in this sector are changed. If you haven't realized that, if you haven't realized that whatever you were doing before is dead, then you're in trouble. Really, I can't stress enough. And anyone who's entertaining you with these conversations, who's convincing you it's not dead, is either taking the mickey or they're dead and they don't realize it yet either. And I think, you know, what I would urge you to do is try and position yourself, and even if that's a branding thing, but try and position yourself more as a provider rather than a supplier, because the white paper talks more and more about provider collaboration. It doesn't mention suppliers. And this digital health company that I'm involved in at the moment has spent a lot of time and effort and money repositioning themselves as a partner, as a provider, rather than a supplier that people buy stuff off. And that has totally changed their value proposition. It's totally changed what they're bringing to the system. So do I provide widgets for people with COPD, or do I improve the care of people with COPD? Do I provide a drug that helps people with urinary problems, or am I helping people with urinary problems? And I think it's all about how you position yourself. And this paper said it all. Partnerships are the way forward.
Wow. Mike, thank you. As always, not controversial. You held back, as you always do. We have had some questions come in, but firstly, I've got a couple from our many discussions. One of them is quite obvious, which is you mentioned waiting lists and waiting times.
Yeah.
How is the NHS going to justify the increase in waiting times post-COVID when 90% of acute trusts have had their debts wiped out? And whose head is going to be on the chopping block 24 months on from that time when the waiting lists are still going the wrong way? So what is the action plan for waiting times in your eyes?
So I think that, they're going to kick the can down the road. So first of all, they're going to blame COVID. And I think they've probably got about 12 months of blaming COVID. They're going to blame COVID for everything. They're going to blame COVID for the fact their stationery got printed on the wrong paper. It's COVID. And we all know that's BS. COVID has just has magnified this. In terms of how they're going to do it, it's going to be 3 or 4 things. First of all, and this is me being super cynical, and there's a difference between how I think they should do it and what we can do to help people do it and what they are going to do. So first of all, they're going to wait for a lot of people to die on waiting lists, because that sorted it in the past. And, hip replacements, etc. And, people with cardiovascular health, etc. Because broadly speaking, if you're on the waiting list for somebody in respiratory, you've probably got cardiac problems as well. A lot of you will have cardiac problems as well. So you'll die of something else, which is awful, but a sad fact. The final thing is they're also going to ration care, which is the only thing, and they have to. The number, if you look at the number of procedures that have been put onto a low priority treatment, or non-clinical essentially, or limited clinical effectiveness, or whatever they're labeling them these days, that list is going up, and the criteria, the hurdles people have to jump through will get considerably higher. So there'll be that as well. There'll be some degree of trying to shift services into the community, but the problem is that how that done is the key. I think that actually the answer lies with that last one, really. I think that there's clearly too much activity that takes place in a hospital. There's too much activity that takes place in a medical facility. Do you know the best place to deliver care? In the patient's home. Really, it's the only way to do it. Who's the best person to deliver it? The patient or a member of their family. And then if it needs more, just work back from that rather than start in the hospital and work your way back. And I think, in every project I've been involved in, and I've been doing this sort of stuff for around 15 years, it's, can this stuff be done in the community? Can this stuff be done at home? Not, what services in the hospital can we move out? So in terms of who's going to be on the chopping block, I rather suspect it's going to be CCGs. So I think there'll be a lot of finger pointing and waving saying, I can't believe this CCG was in charge for 8 years and they did this. And because it's easy to blame someone who's not there, who's dead. Yep. So when they run out of blame with COVID, they'll start blaming CCGs. Mark my words, Public Health England was the first on the chopping block.
Well, thank you, Mike. We've had a question from Simon, which is, will NHS England retain responsibility for specialised commissioning? The
short answer is we don't know. The ICSs are pushing for no, because they think they've got a big enough geography to do specialist commissioning. I just know that NHS England, when they promised in 2012 to be a hands-off, light touch organisation, if anyone thinks NHS England has been sort of a reduced body, light touch, they are smoking some serious crack, because they are the most heavy touched, over indulgent organisation ever. So You'd hope that. There's a suggestion that they're going to devolve this to the ICSs, but you know, the other complicated factor on this is, don't forget that the chief executive of NHS England is standing down, and you know, those of you who have ever been in any organisation where they've had a new chief exec, how many times do they go in and go, oh, the previous person was completely right, I'm going to continue all of their ideas because they were really good, business as usual. No one ever does that. So someone's going to go on and put their own mark on the job. Stevens totally changed things around after Nicholson, and whoever replaces Stevens, he's going to basically shred all of Stevens's fan mail and do his, and I say he because I'm just hoping it's not Dido Harding. Really, God, have you ever been with Talk? Yeah, so I think it's it'll be interesting.
And for those who don't know, Dido Harding was their latest claim to fame was track and trace. That took 3 times the budget of Department of Health and didn't work. No,
let me tell you about this, Steve. So the budget was 37 billion for track and trace, track and trace. Let's put that in context. So that is that's 10 times Tesla's entire development budget. Okay, that is 4 times the entire budget of primary care. But that could fund the lunar Mars module 20 times, you know, and let's not forget it didn't work. So this we bought a pup as the taxpayer, but actually it was Public Health England's fault, so that's why we got rid of them.
Yeah. One other thing that comes to mind is the other big bit of news that's pretty much been bypassed is the changes to the GP contract. And I think you've mentioned previously about the drop in income to GPs because of the changes. Now, surely that presents a massive opportunity for industry too, don't you think?
Yeah, I do. And I think that, you know, the thing about it is there'll be 2 types of GP. There'll be those who capitulate and say, look, take us over to the ICS. And they basically will go to the acute trust and say, look, we'll continue to work in doctors in your ICS. Can you make all the decisions for us? And then there'll be the entrepreneurial ones who'll be looking for alternative sources of income and alternative services. And I think that I can't tell you the percentage of them because, you know, it's been a really strange year. And I think that, you know, a lot of people are planning to retire or scale back in the coming months. You know, we're going to lose 1 in 10 GPs, the BMA reckons, in the next 12 months. And bear in mind, the numbers were falling anyway. And why is that important? Well, a lot of those GPs were decision makers, and they had the organizational memory to be able to make decisions around things. Okay, so I think that it's a fantastic opportunity. What I wouldn't do is I would be quite selective about who you contact and, you know, who you reach out to, because there'll be a lot of time wasters.
On the one hand, Mike, you're saying that there's going to be like a 10% reduction in GPs, and I totally get that. And on the other hand, you're saying there's going to be a big push by ICSs to move services out of hospitals. So that one thing is creating more work for the thing that's then shrinking. So how is that going to work out?
Simon, welcome to my pain. Welcome to my world. I've no idea, Simon. I've no one's thought it through. And so the serious answer is, and I can tell you this, NHS England have said, well, actually, we've realised that we'll try and do as much of these services without GPs. So, you know, it's quite interesting, isn't it, that rather than pay GPs more money, which is how they increased the numbers before. Jesus, they got me into general practice by promising me more money. You know, I left plastic surgery, for Christ's sake. What an idiot I am. I arrived. You know when you arrive at the party and all the best food's been eaten, all the best booze has been drunk? That's literally my career in general practice. I saw the gravy train just pulling out of the station going, oh, wait. And all these buggers had all benefited on the new change in contract, all the golden handshakes. Story of my life, really. But instead of doing that this time, what they did is they incentivized GPs not with money, but saying, I'll tell you what, we're going to give you £1.3 billion in general practice. Oh, but you can only spend it on workforce. Oh, And not only that, you can only spend it on particular members of the workforce. So we say, can we spend it on doctors? No. Okay. Can we spend it on nurses? No. Okay, what can we spend it on? Well, we're going to make up some roles because they're cheaper. Okay, what are these roles? Okay, so there's going to be a social prescriber. Okay, what is a social prescriber? Well, it depends where you are in the country, because I can tell you a social prescriber in Dartford is very different from a social prescriber in Dartmouth. So it's, you know, I think that what the NHS England's plan is to flood primary care with non-GP workforce, because, and they will publish this figure, another Mike prediction, there will be a figure churned out by NHS England and the government to say how much the primary care workforce has increased in the last 24 months, because it has. But I've got people walking around my practice and I don't know what they do. They're employed by the PCN. I don't know what they do on a day-to-day basis, because it sure as hell isn't doing my work. So the short answer to your question is that's how they think it's going to work. How it actually happens is going to be very tricky. Now, look, to sort of show you I'm not that cynical, maybe it's just a Tuesday afternoon. I think that there is some things that clearly can be done without the need of a doctor, and just the maybe the oversight and the risk management of a doctor. But I think that, you know, it will require a lot of support and a lot of hand-holding. And I think, once again, in terms, I always try and see opportunities in these things. I think that anybody who wanted to get in this sphere, if you said, look, rather than here's my product, here's our expertise, here's our hand, let us hold you through stuff, let us help you develop this and get this up and running so you don't actually have to increase your workload. And bear in mind, I keep on saying, if you can reduce a GP's workload, they will bite your hand off. It's the one thing that if someone said you could earn X% less, but I'll reduce your workload by 2X, I would take it. You know, whereas traditionally GPs would work harder for a slight increase in money. We're all burnt out. I mean, I work 2 days a week now, and I feel every hour of those 2 days a week, every bloody hour of it.
Well, I think there was a point that you made earlier, Mike, about all of the constant changes. So I think it will at least keep us busy with webinars on all the stuff that's happening in the NHS.
And podcasts.
And trying to keep up with what's happening. So I think that will keep us busy at least for the next few years.
Well, if you just to think, if you want to hear what an ICS is, and bear in mind I've recorded this week's podcast, we've got myself and 2 experts trying to define what an ICS is, and in 21 years I have not had a more hilarious conversation, and it is. I think if you listen to it, you'll know exactly where ICSs are. So much so, I had to cut about 5 minutes of laughter out of it. But there you go.
Brilliant. Well, thank you very much, Mike, for another excellent talk. If you can flick it onto the last slide, we'll just kind of finish off there.